My brief is to talk about optimizing the Mako robot in the operation theater. We have been using it for the last 7 months, and every day is a learning. I think we have got so much better than when we started. By definition, optimization is making the best of the most effective use of the resource. And that's what we are trying to do to achieve what we want to achieve without a compromise, at the same time make it more efficient. This is based on a 3D model of the patient's bony anatomy with a CT scan. Gives you ahead of time what is the size of the implants, and to a large extent you can decrease the inventory if you know pretty much what size you're using. And by and large we are able to predict and act it out exactly what size of implants we use. This is one little advantage. Intraoperatively, it gives real-time dynamic assessment of the ligaments, and you can change what you are going to be doing depending on the ligament feedback, what you get while you're operating. The steps are very same. First, the CT scan, the segmentation is done. Preoperatively, your planning is done. And then once the planning is in place, the OR setup, which I'm going to talk about, I don't think it's any different from most of the robots. It will be a repetition. The array placements are important. And then the bony landmarks are mapped. And intraoperative ligament adjustments, like I said, bone resections. This is purely a semi-automatic one, so it's a robotic arm which helps you do the cuts, and it's pretty much accurate and pretty easy to do this. Trial reduction, and finally the final implantation of your implants goes exactly as you are prepared. When we talk about optimization, which is the brief, is how can you optimize it? We have done this conventional one, again with the team effort and everything else. Here it is no different. It's a team approach, step-by-step workflow. Don't try to, the typical surgeons, we try to be smarter than what has been told, and the very first time we want to modify. That's not the way to get smarter with these things. Go step by step. Regular training of the staff in the robotic setup is very important. You don't want to have bull in the china shop disrupting what you're doing. We attribute our success to the reproducible steps, well-defined responsibilities. Everybody knows exactly what they have to be doing, and a consistent surgical team. That's very important. The surgeon assistant and the nurse are, of course, we have spoken about them. This is something very unique, and I found it extremely useful, the MPS. It's a Mako product specialist. While he may be 12th standard pass, but when he's trained aggressively, he's of great help. You can sit with him and plan. Initially, his help is much appreciated, and as we go along, obviously we get smarter and better. I've been to the place where they train these people. It takes weeks of intense training. This is the Stryker headquarters in Mahwah, and they are trained extensively, intensively, and the data they have when they train is quite amazing. It's the global data available, and all the variations are taught to them. So that's very important. 3 steps here, 3 equipments basically: the robotic arm, camera stand with the surgeon monitor, and the guidance module, which the MPS is going to hold out. Again, about efficiency, maximizing the benefit of CT-based preoperative planning and templating, which makes it whole surgery very predictable. Maximizing the number of steps completed before the surgeon enters. I think we have spoken about it before. Even before the surgeon enters, most of the regular steps are done and kept ready. And you don't have to do one at a time. You can do things simultaneously so that it will be much quicker and more efficient. Robotic OR room needs to be quite roomy, because this Mako is a bulky one, so you need a little bit roomy one so that you don't trip over each other and the contamination doesn't happen. Load the preoperative plan on the monitors, verify all the equipment operations, place the robot in the right place for surgery. These are simple things, but extremely important to be done even before we take off. That's typically the arrangement, not very different from anything we have seen today. Patient positioning, you learn as you go along. Even the side support, what you use, needs to be appropriate. It doesn't knock the robotic arm which comes in to do the cuts. So one needs to be careful and one needs to adapt. There's some interesting safety things. This is because it's a semi-automatic mounted one. The saw can go off sometimes in the wrong place, so it has got a feature where it warns you if it is in the dangerous zone. These arrays can be a big pain. You can use them. Sometimes they don't clip on very well and they tend to fall off, especially because we reuse them 3 to 4 times. That's when it can be a little difficult. But they give it becomes a simple habit once you start doing. That's typically the drama, what happens inside. And this is one of the frequently quoted drawbacks is it consumes time, like all of us have spoken. But to be honest, time consuming is okay. If it adds value, it's very important. For patient, it's one surgery. For you, it may be 10 minutes less, but what's important is to get it perfectly right. Conventional skin to skin, we take 60 minutes. Robotic takes 70 minutes. And we are improving on this on an everyday basis. What's more interesting and what's more promising for me is it takes away the surgeon's experience. It becomes very predictable, and even if a young man who's got this whole gadget with him can perform a surgery as accurately as you have done or a senior person has done, for me that is the biggest gain of technology beyond anything else, because you can verify your ligament balance, you can verify everything else, and you will see exactly the same result as an experienced surgeon. For me, that's the biggest leap. One needs to lastly think, some things are for surgeon's comfort, some things are patient's benefit. One needs to weigh the pros and cons of this. Quite often what doesn't suit the surgeon, but even if it is good for the patient, we don't tend to do it. That's not the way we should be looking at. What ultimately is important is the outcomes and what works best for the patient. Thank you very much.